applause.
Okay, this has been an awesome event. This is actually my first time attending, and I think this is awesome. A ton of food, great venue, great speakers. Dr. Oblock is here today. He's a sleep specialist working at the Paoli, Newtown Square, and Riddle locations of Mainline Health. Dr. Oblock went to medical school at the University of Pennsylvania, trained in neurology at the University of Michigan, and completed his fellowship training in sleep medicine at Harvard University. Dr. Oblock has served as a clinical instructor at the Harvard Medical School before returning home to Philadelphia. Dr. Oblock's practice currently focuses in on sleep medicine, and he has a growing pediatric population of patients, which is his subject today. Dr. Oblock has a quick wit and a terrific sense of humor and takes great pride in the care and treatment of his patients. So everyone, please, nice round of applause for Dr. Oblock.
So I will try to keep this reasonably brief. I know that we're all getting ready for the Eagles game on Sunday. I have my Eagles cufflinks on here. You probably can't see them, but I promise you I do. There was a guy sitting in the back there with a Dallas Cowboys hat. Exactly. That's right. Now I was concerned because I saw him here and I said, if there's a Dallas Cowboys fan, I'm going to have to speak very slowly. Now that he's gone, we should be able to run on time. I'll do my best. Okay? So I'm going to talk for the first 30 or 40 minutes. There's an orthodontist who I collaborate closely with. I'll introduce her at the end of that time. And you'll see sort of how my work overlaps with hers. I'm going to discuss pediatric sleep apnea. Thank you for that kind introduction, Mike. In terms of pediatric sleep apnea demographics, roughly 1 to 4% of 5 to 18-year-olds are likely to have pediatric sleep apnea. This is actually a spectacularly high number. You can imagine that if there are 100,000 children of this age in Delaware County and 100,000 children of this age in Chester County, 200,000, say 2,000 to 8,000 5 to 18-year-olds with sleep apnea. We all probably know somebody who has sleep apnea, a child who knows sleep apnea, but is not diagnosed at this point. Sleep apnea is more common among black children than white children. By puberty, males tend to have sleep apnea somewhat more than females. In terms of risk factors for sleep apnea, we're familiar with some of these. Adenotonsillar hypertrophy, large adenoids, large tonsils block the airway. Obesity is an always growing risk factor among children. As are specific risk factors like craniofacial abnormalities, in particular Down syndrome. Kids with Down syndrome often have very severe sleep apnea. Many of us have seen adults with Down syndrome with very severe sleep apnea, along with neuromuscular disorders. Many of these children with genetic syndromes, though, end up requiring comprehensive care at a tertiary center like DuPont or CHOP. In terms of further risk factors, inadequate maxillary development. So the idea of a narrow maxilla is something we will return to as I speak further and as Dr. Evans speaks further. The maxilla is the bone behind the nose. It forms the roof of the mouth and the base of the nasal airway. You can imagine if this is too narrow, then nasal breathing is difficult, oral breathing can be impaired as well. Retrognathia, a small chin. Acid reflux is associated with sleep apnea in children. Sickle cell disease is highly associated with sleep apnea, and sleep apnea carries a particular morbidity in patients with sickle cell disease because it can precipitate a sickle crisis. Secondhand smoke may be a risk factor for pediatric sleep apnea. Family history of sleep apnea appears to be a risk factor as well. In terms of the symptoms of pediatric sleep apnea, hyperactivity is common, inattention, aggression, poor school performance, poor appetite, daytime sleepiness, and headache. However, in contrast to adults, the symptoms in children are more often hyperactive and inattentive than sleepy or fatigued. In terms of nighttime symptoms, children with sleep apnea are more likely to snore. They have witnessed difficulty breathing at night, witnessed apneas, restless sleep, frequent awakenings, nocturnal sweating, wetting the bed, dry mouth. On exam, and these are clearly overlaps with some things I've discussed before, we may note obesity, mouth breathing, a high arched palate, a narrow maxilla, tonsillar hypertrophy, macroglossia, or a large tongue, retronathia, or short stature. Sleep apnea may impair growth. So when we look at diagnosing pediatric sleep apnea formally, in addition to polysomnographic findings, there do need to be some nighttime or daytime consequences, as in snoring, labored or the appearance of labored or obstructed breathing at night, or sleepiness, hyperactivity, behavioral problems, learning problems. As I noted, in children, hyperactivity, behavioral learning problems are more common than sleepiness during the day. On the polysomnogram, the requirement is 1 or more obstructive apneas, mixed apneas, or hypopneas per hour of sleep. So this is quite a small number. And this is part of the reason why pediatric sleep apnea is difficult to pick up on home sleep testing, and therefore part of the reason that we do not use home sleep testing in children. Or a pattern of obstructive hypoventilation defines with 25% of sleep time in hypocapnia, with a PaCO2 greater than 50 millimeters, associated with some evidence of inspiratory obstruction, like snoring, flattening of the inspiratory waveform, or paradoxical thoraco-abdominal motion. And this is why in children we monitor carbon dioxide. As noted, in adults, we can do in-lab testing, we can do home sleep testing. This is, as all of us have gone through recently, as all of us have dealt with, there is a role for home sleep testing in the diagnosis of sleep apnea in adults. However, in children, there really is not adequate evidence at this point to recommend home sleep testing. Insurance companies do not pay for home sleep testing in children. In terms of testing, this may seem intuitive, but I don't think this is always part of the standard care that children at risk for sleep apnea receive. The baseline polysomnogram is important to identify the presence and severity of sleep apnea, because symptoms, physical examination, and any laboratory tests do not predict PSG findings in children. Why is this relevant? Because this is the most common approach to pediatric sleep apnea in the country today. So parent comes into a pediatrician, says, my child snores, maybe says my child has some problems with hyperactivity in school, commented. The pediatrician sends the child to an ENT. The ENT looks, says you have big tonsils, and the ENT takes the tonsils out, takes the adenoids out, and then says, good luck, you've been treated for your sleep apnea. And you'll see as we go forward, there are several issues with a treatment course like this. First of all, we don't know if the child had sleep apnea to start out with. And second, as I will argue in several subsequent slides, many children who have adenotonsillectomy continue to have some degree of sleep apnea. All of us are familiar with adult scoring criteria. So major differences between adult and pediatric scoring criteria in terms of severity by age. In the adult, mild sleep apnea is 5 to 15 events an hour. In children, 1 to 4 events an hour constitutes mild sleep apnea. There is some debate about this in the pediatric literature. Some say 1 to 4, some say 1 to 5, some say 2 to 5. The ICSD-3 says 1 to 5. Again, some degree of variation. Moderate sleep apnea in adults, 16 to 30 events, and in children, 5 to 10 events. Severe sleep apnea in adults, greater than 30 events, and children, greater than 10 events. In terms of key scoring differences between adult and pediatric in-lung studies of obstructive sleep apnea. In adult, must last for at least 10 seconds. In children, that's 2 breaths. Because children, as they go through different developmental stages, tend to breathe at different rates. Hypopnea duration, same thing, breaths instead of a specific time criterion. The hypopnea definition remains exactly the same, standard 30% decrement associated with either a 3% desaturation or arousal both in adults and children. In adults, we rarely measure carbon dioxide. In children, we're looking for evidence of obstructive hypoventilation, which can be which, as I noted before, is one of the ways that we can define obstructive sleep apnea in children. In terms of age, this is another area of debate. For children younger than the age of 13, we always recommend pediatric criteria. For adults over the age of 18, we always recommend adult criteria. Between the ages of 13 and 18, different people would use different criteria. On some level, we try to tailor the criteria used to the maturity level, to the physical maturity level of the child. That's a challenge. In terms of how does sleep apnea how is sleep apnea manifested in the adult brain as opposed to in the pediatric brain? Obstruction very often leads to an arousal in adults. You can see this arousal on EEG. In children, an apnea may lead to an arousal on EEG, or it may simply lead to movement or tachycardia, what is described as a subcortical arousal, meaning that the cortex, the gray matter of the brain, may not be involved. In terms of sleep architecture, adults with sleep apnea typically have very disrupted sleep architecture. Children with sleep apnea tend to have somewhat less disrupted sleep architecture. As noted, some apneas do not lead to full arousals in children. And second, pediatric sleep is just very hard to disturb. Kids sleep more solidly than adults. In terms of purely REM-related frequency, adults sometimes have exclusively REM-related sleep apnea. Children often have sleep apnea that only occurs in REM sleep. So, to elaborate on some of the behavioral consequences of what happens when children do have sleep apnea, in terms of hyperactivity, there have been multiple observational studies suggesting that there is a correlation between children who are hyperactive and children who have symptoms of sleep apnea. In terms of inattention, I would say the same. There's a clear correlation between children who have inattention and children who have sleep apnea. There was a recent study of 3,000 children. Parents filled out questionnaires reflecting the child's likelihood of having sleep apnea and of being aggressive, and it turned out that among these 3,000 children, those whose parents answered questions suggesting sleep apnea also tended to have higher rates of aggression noted in school. Sleep apnea and attention deficit disorder correlate. So realize that in this slide, I'm presenting correlational evidence. I'm not making a clear case that sleep apnea causes all of these things. However, based on the amount of correlational evidence that we have, and based on some other things that I'm going to discuss, if we look at the American Academy of Pediatrics' most recent set of guidelines regarding sleep in 2012, there was a clear statement that obstructive sleep apnea in children impairs neurobehavioral development. This is something that no parent would want for a child. In terms of cognition, sleep apnea and low IQ seem to correlate. We haven't been able to show a clear correlation between sleep apnea and memory loss. Sleep apnea correlates with poor school performance. In terms of vascular consequences, children with sleep apnea have higher rates of high blood pressure and pulmonary hypertension, along with left ventricular hypertrophy. Children with sleep apnea often become adults with sleep apnea. So let's start to discuss treatment. So in patients diagnosed with attention deficit disorder, studies suggest a clear improvement in children with a baseline AHI of 1 to 5, whose parents elect adenotonsillectomy compared to no treatment. So it seems that you take out the adenoids, you take out the tonsils, you get some benefit. Now, part of the trickiness of interpreting studies like this is that in these particular studies, the children were not actually randomized to get an adenotonsillectomy or not. It was more like, you as a parent chose adenotonsillectomy or no adenotonsillectomy, and then two cohorts were compared. So this doesn't live up to our to how we consider evidence to be a gold standard, and that is the randomized clinical controlled trial. This is the largest one to date. It was published in the New England Journal in 2013, the CHAT study, the Childhood Adenotonsillectomy Trial. So, 464 subjects, 5 to 9 years old, AHI of 2 or more. These kids were randomized either to adenotonsillectomy or watchful waiting, and various outcomes were measured afterward: polysomnographic, behavioral, cognitive, and health outcomes at 7 months. Okay. So what does this show us? To summarize this finding, their primary outcome was this NEPC score, which is kind of at the top here. And it turns out that for the NEPC score of attention and hyperactivity and ability to direct attention, this was actually a negative study. It turned out that, in our best evidence to date, you take kids with sleep apnea, take their tonsils out, and technically, this study did not find a statistically significant improvement with tonsillectomy. Now, in several secondary outcomes, which were also measures of attention and behavior and quality of life, there was a statistically significant benefit. And finally, in terms of change in apnea-hypopnea index from beginning to end, the baseline median apnea-hypopnea index was 4.8. And at the end of the study, it was 3.5 points lower, so 1.3. Now, so one of the challenges here is, do we say that, do we conclude from this study that adenotonsillectomy does not provide adequate treatment of attentional syndromes in children? Or do we conclude that perhaps adenotonsillectomy alone is not sufficient? And I would argue that if the median AHI is 1.3 that's left over after adenotonsillectomy, at least half these kids still have sleep apnea by the ICSD-3 definition. So even with adenotonsillectomy, a lot of sleep apnea remains. So even by the criteria used in this study, 21% still had an AHI of 2 or greater, so still had sleep apnea by the standards of the authors. And then what happens after 7 months? So our best data for that, coming from Sleep in 2014, suggests that kids with sleep apnea, so this is a group that had very severe sleep apnea to start, a median AHI of 14. Okay, they underwent adenotonsillectomy, and then their median AHI dropped to 3.5, which is great. Over time, their AHI started to rise. And this is a significant rise over 3 years to an AHI of 6.5. So I look at this and I say, well, what else can we do for children who have sleep apnea, who get adenotonsillectomy, who still have some degree of sleep apnea? One option is positive airway pressure. This is generally recommended for kids with at least moderate sleep apnea. It does reduce positive airway pressure, needs to be titrated for kids with sleep apnea. Adherence is a challenge. Sometimes we favor BiPAP in children, although we don't have clear data that BiPAP actually improves adherence rates. Overall, I would suggest that adherence is likely somewhat lower than in adults. When I look at the literature, when I look at my own experience, the number that I kind of come to would be roughly 1 in 3 use positive airway pressure over a meaningful period of time. So other treatments. You can use nasal steroids, montelukast. The idea is you reduce inflammation, you reduce adenoid size, they help kids breathe through their nose. Oral appliances, as in adults, they confer some benefit. One concern is that if you give a child an oral appliance, you could alter their their cranial development. They're still, because kids are still developing, changing maxilla, mandible over time. Weight loss can clearly improve sleep apnea in children and adults. Always easier said than done. So I'm going to introduce this concept of rapid maxillary expansion, which I think is important, and which Mariana Evans is going to follow up on. So here's a study from 2004 where 31 children had an average AHI of 12 and a mean age of 8.7. And so here's what happened. So these children were noted to have a narrow maxilla, which is a judgment that a dentist or a physician or an orthodontist can make. And a simple retainer is made. And that retainer is placed non-surgically in the roof of the mouth. And you just exert outward pressure on sort of the lateral teeth or the bony structures underlying the teeth. And the maxilla begins to expand. And when you expand the maxilla, other things follow. The nasal passageway becomes expanded, so kids who were mouth breathers can become nasal breathers. Sometimes the mandible expands as well, so kids who are retrognathic can develop a more normal mandible. And you see the overall airway expand. We'll show you pictures of this shortly. So these kids underwent maxillary expansion, and after 4 months, all of them had an AHI less than 1. Now, I think I do take this particular study with a grain of salt, because the magnitude of effect of maxillary expansion here has not been replicated in other studies, but most studies have shown some benefit. And here's what Principles of Practice of Pediatric Sleep Medicine says. RME is well established as an effective non-surgical treatment option for decreasing upper airway resistance through increasing upper airway volumes. I will tell you that if you look around at the kids being treated anywhere in the country, it is very, very rare for them to undergo maxillary expansion. And I think the bottleneck is that it's hard to find orthodontists who do this well and effectively. So, in terms of maxillary expansion and adenotonsillectomy, so here's the gist here. 31 kids were taken into the study, 70 girls, 42 boys, average age 6.5. On average, they started with an AHI of 12.5 and 11, and then all of them got at least one treatment, either the surgery or the maxillary expansion, and then whoever got one treatment then got the other. And the idea is that after one treatment, each of the kids had an AHI of roughly 5. Okay, so their sleep apnea was cut in half by either maxillary expansion or adenotonsillectomy. Then the kids got a second treatment, which was either adenotonsillectomy or maxillary expansion, whatever they hadn't had before. And their AHIs overall went from 12.5 to 1. And I think this is I think this is compelling evidence. In terms of the long term, in this study of maxillary expansion alone, at baseline these kids had AHIs of 6.3. And after several months of treatment, their AHIs reduced, declined to 2.4. After another 2 years, so essentially 3 years after the baseline time point, their AHIs remained at 2.3. So there was some persistence of benefit of this maxillary expansion. And so, again, Mariana will give you a little more detail about what we do, or about what an orthodontist can do to sort of foster this maxillary expansion and to expand the airway. But here's sort of the rubric that I would suggest based on what we know about the treatment of sleep apnea in children. A child comes into a pediatrician's office, the parent says, my child is snoring, has some problems with attention. A sleep specialist sees the patient and, if appropriate, obtains a baseline polysomnogram. And the baseline polysomnogram, again, this needs to be an in-lab study in kids. If the baseline polysomnogram demonstrates sleep apnea, then the child ends up seeing an orthodontist for evaluation with 3D imaging, along with an ENT. And then, ideally, all of us come together and talk. And this is a tricky thing in medicine. I think there's far too little discussion amongst doctors of cases because we're not incentivized to do so. We don't get paid for discussing cases. But we get together, and then we say, is the problem here the airway? Is the problem here that the airway or the pipe is too small? Is the problem that there are large adenoids and tonsils here that are blocking the pipe? Do we need to open the pipe, or do we need to do both? And then we come together, we make a recommendation. We do one of these procedures that I've discussed, expansion, adenotonsillectomy, or for positive airway pressure if we don't see a clear target. And then we repeat the polysomnogram. And if the child still has sleep apnea, then we talk again. And we figure out if an additional treatment is necessary. And at times, if necessary, we're willing to use positive airway pressure as well. So, at this point, I'm going to introduce Dr. Mariana Evans. We'll take questions at the end. So, Dr. Evans and I are collaborating on this approach. Dr. Evans did her training at the University of Pennsylvania. I think when we think of orthodontists, a lot of the time we think of people who straighten teeth. It turns out that the tools of orthodontics are actually incredibly powerful in remolding skeletal structures and in growing the airway. And I think that Dr. Evans is a pioneer in this area. I think she's one of the few people who's looked at this data and has come to appreciate the power of some of the techniques that orthodontists can apply. So it might take us a moment here to reset some of our audio visuals, but we'll be back with you in a second.
With sleep apnea and also prevent sleep apnea in young children from developing in the future in life. So I'm not a medical doctor, I'm not a sleep specialist. I am an orthodontist and I'm a periodontist. My practice is in Newtown Square, and I also half of my time dedicate to teaching at the University of Pennsylvania. And the reason why I am here with you today is because the orthodontics is significantly changing. And it's changing because of the new technologies that we have in orthodontics today to evaluate patients' skeletal pattern and to evaluate patients' dentition, and we can also see the airway. So in the future, as we are actually starting to work in this direction with Dr. Abalok, but I think sleep centers, sleep technicians, and orthodontists and sleep doctors are going to collaborate significantly in this field. So you won't believe, but you can actually use facial appearance and dentition of the patient as a marker for screening for patients with sleep apnea. So what technology we have today in orthodontics? Unlike in the past, when we used two-dimensional images, today in orthodontics we are actually starting to use three-dimensional images. And it's not a conventional CAT scan technology that you are used to see in medicine. This is actually called a cone beam scanning. It's a very low radiation imaging that allows us in a matter of 4 to 8 seconds to receive like a three-dimensional image of the soft tissue structures and the bony structures in a similar quality as you get with conventional CT, but the radiation much less. For example, if you have a conventional CAT scan, your patient will probably receive radiation of 1,500 microsieverts. When you take a cone beam technology that is going to give you the same quality and the same information as the conventional CAT scan technology, you will only receive from 20 to 50 microsieverts of radiation. So when I take my conventional radiographs that I use in orthodontics, as you can see in the top of the slide, the radiation that my patient is receiving over the treatment time is probably less if I use three-dimensional images. So three-dimensional images are going to give me three-dimensional one-to-one ratio representation of the skeletal structures, of the teeth, of the periodontally supporting tooth structures, as well as the airway. So today, in my practice, I look at the airway of the patients routinely. Whether it is an adult patient or a child, I have to look at it because it's part of my diagnosis today. So we also have a very significant advances in the software that we have, that we use with those 3D images. And the software that we use today in orthodontics allows us not only to take the very accurate measurements of the bony and tooth structures, but also allows us to measure the airway three-dimensionally. So as you can see, these two patients are two different patients, but this is their airway. And the patient on the left side is the patient with very significant constriction of the upper airway. This is where you can see, do you have, like here, for example, you can see that the patient has significantly enlarged adenoids, and the airway is outlined in color. So on the bottom of the slide, you can actually see the scale of the volumetric measurement. And the scale usually will tell you how big the airway is and where the obstruction comes from, because not always you will have a true obstruction by the soft tissue such as tongue or adenoids on tonsils. Sometimes you just have a retruded or posterior position of the upper and lower jaw that will make the airway much smaller. And when the patient is sleeping in the horizontal position, the tongue always will go more back and obstructs the airway even more. Okay, thank you. So here, for example, you can see a scale, and the scale goes from black to white. So if we want to have a healthy patient with a healthy airway, we would like the colors of the airway to be between green and white. So here is, for example, a patient with a very healthy airway, and the volume, as you can see, is around 22 cc. And here is a patient with yellow to black airway volume, and the constriction is right where the adenoid